quickly we'll go to the OT. Namdev, you can go ahead with us. Tell us what has been done so far.
Yes, sir. Can
I'll request Prathamesh Jain. Prathamesh, are you here, Prathamesh? Ali Magdes. Nilesh Kamath is not there. Vivek Pandey. Vivek, please be on dais. Jiten Maheshwari. Ayyappan Nair.
Arthroscopic view.
Dr. Saeed Althani, Saeed and Ali Magdis. I think both of us sitting here just went out. Okay.
Roshan sir, can you hear us? Can you hear us?
Yeah, yes, Namdev. Before we go on to Stump the Professor session, just let us know what has been done in 1 minute.
And we have repaired the capsule labrum here. You can see, now you cannot see the graft here, sir.
Yeah, we could see the Bankart repair with bone block, yes. So anterior-inferior labral repair along with the bone block.
See the tensioning of the anterior band of the IGHL here?
Yes.
See?
Okay.
Yes.
Thank you. Thank you. That was a wonderful demonstration. Sir,
Yes.
we are perfectly on time.
As handsome.
Thank you, sir.
You can go outside now.
Yes. Now finish.
No, we have another two panelists. Dr. Desai.
Here, look here posteriorly. Don't forget.
Dr. Desai, we have another two panelists. Let it be there, no problem. Continue.
Super.
So,
Thank you. Thank you.
Okay, understand?
One picture you want? One picture?
Picture.
up to, this is 11:20, you have 30 minutes. Dr. Desai,
Sorry?
you have 35 minutes for panel discussion.
Fantastic. That's
Thank
more
you.
than enough to cover the whole of instability. So thank you very much, Roshan, for giving me this opportunity and for the invitation. We have a very high-powered panel. As the panel is familiar, my request is that be short and sharp. The idea is that we can show more cases. I have a collection of 5-6 cases, and the idea is to cover the whole gamut of instability in those 5 or 6 cases. So, and if I interrupt you or intercept you, no offense, please, the idea is to show more cases. So here is a 28-year-old male, a very typical classical day-to-day case. Late 20s, 5-6 dislocations in 2-3 years, post-traumatic, कभी-कभी weekend को sports खेलता है, cricket वगैरह, badminton, and has 14% bone loss with a on-track small hill sacs. So Pratap, what will you do? Just one simple answer quickly.
Can I get some more information? Has he got a?
You can ask me.
What is the Beaton score?
What?
Beaton score, ligament laxity. Has he got any ligament laxity?
Ligament laxity, mild laxity. Mild.
5. Okay. So I think so standard 128 years, 14% bone loss. So I will go with the Bangart's repair and remplissage.
Even for a small hill sacs.
Yeah.
You will do a remplissage.
Yes, because 14% bone loss. That is why I'm adding a remplissage there.
But that small hill sacs will tackle the 14%.
That's okay,
bone
but
loss.
I am taking the concept of a bipolar lesion here.
Okay. Ayyappan.
So again, Bankart remplissage, and if the head is still not centralizing and stable, then a DAS procedure. Sir,
Sorry.
sir, you can hear me, sir? So what I was saying is I do a Bankart remplissage, Bankart and remplissage, and if the head is still unstable, because in some cases it can still be unstable, then I do a DAS procedure.
Okay. So Ayyappan, how will you decide on table after doing a Bankart and a remplissage that the head is still unstable?
Yes, sir. So it's pretty interesting when we actually look through the anterosuperior port or a superior port. From that particular port, you can see if the head is central or not. My end point of repair will be till the head centralizes entirely in the glenoid. So if it is still subluxed anteriorly after my repair is done, then I would definitely do a DAS, because that means it is not centralized. There are still chances of this coming out. That's my
Okay.
end point.
So audience, you heard that. In my experience, ऐसा कभी होता नहीं है. Once I repair the Bankart in our 12-14% bone loss, the head usually centralizes. So stop there. Remaining panelists, have you ever experienced that you did a Bankart repair and the head is subluxating from the anterior-superior portal? Ali over there, you heard what Ayyappan said. You do a Bankart repair. After the Bankart repair, if the head is still looking subluxed from the Ayyappan, am I correct in interpreting what you're saying?
It is not subluxar, it should be center.
It's not centered. I think it's the same
I understand.
language. That it's still not centered, and then you will do something else like a DAS procedure. So forget the DAS. Have you ever encountered that you did a Bankart repair and the head is appearing to not having been centered? Yes or no? Just one answer.
I think it's a matter of indication before you go into the surgery and trying to attempt your Bankart. If that is something, I have never encountered this situation.
Not DAS. Have you ever encountered this
Yes.
head not being centered?
I have never, but if I do, I would add a remplissage.
I think the health sex here, this is small, but it's a bone loss. So for me, this is where I will indicate some bony reconstruction, like a letter J or a bone block, to help with this patient, instead of just a pure Bankart. I will not stay with the Bankart. This patient with the multiple young guy bone loss, I would go for a letter J or at least some bone block to cover the bone loss.
You would do a bone block procedure.
Yes.
Okay?
I would as well. This for me is an indication for letter J. 6 dislocations in 3 years, definitely significant bone loss in my term. Probably if we have measured it on the CT scan, we would have analyzed a bit more bone loss. Yeah, so for me it's an indication for letter J.
Letter J. Jiten.
I'm straightforward, just Bankart repair in a weekend sports guy, low-key guy, even with 14, 15, 16, 20%, even 20% I would say. For me, the most important is the activity requirement of that guy. He's a weekend warrior. After surgery, he will not even remain weekend warrior, let me tell you. So he becomes quite successful case, just with simple, a good Bankart, good shift, that's all.
Bankart repair. Ram.
Just Bankart.
I agree.
Bankart repair.
Bankart with the remplissage.
Bankart
And
with
I would just add that it is possible to do Bankart and after remplissage, but in my practice, I always decide to do remplissage first. Because to repair Bankart and then check stability and come back makes the surgery very difficult to put the remplissage anchor. So we just decide.
You are aware that even with systematic reviews and a world consensus on remplissage, small hill sacks is not an indication. You are aware of that?
Aware, but he has got some sport activity and the remplissage might support the anterior repair.
Even from the Nick Verma team,
Yes.
multiple trials, small hill sacks, they don't recommend remplissage. And in spite of that, you will do a remplissage. Do you feel that you are overdoing it? No.
No.
Okay. Vivek. Gentlemen, can you come here and pull a chair because I can't hear you because of the echo. Thank you. Yes, Vivek. Quickly.
I would do Bankart. I would do remplissage for sure, because over the years I have realized, I was discussing the same, that when we started re-evaluating our recurrences, since I write my own OR notes for 15 years.
Bankart plus remplissage.
I'll tell you, no, that answers your question. In most of the cases which recurred, they were all small hill sacks, and I said, it's a small hill sacks, doesn't require remplissage, I'm leaving it, they recurred. Now, third point is important, what Ayyappan said, it is once in a while seen that after Bankart, the head appears uncentered. In that case only, we go and then do the remplissage.
Okay. So,
It's not common, but it's once in a while used.
these are the choices now. Audience, if you notice, 2 people have said lethargy. Somebody said bone block, 1 bone block, 1 lethargy, and 1 DAS.
Actually, I will talk to the patient because bone block will create an extra cost to the patient, so I will see what he wants. But for me, this is need a bone filling procedure.
What extra cost?
Depends. Pain for
Sorry,
iliac
gentlemen.
crest and
versus
Gentlemen.
I'm
3
talking.
or 5
Gentlemen,
ankles.
gentlemen. Overruled. Stop. Yeah.
That's quite costly in India.
So I want, this is a generalized question. Forgive me, but I will intercept if I'm losing time. Suppose you do 100 recurrent anterior dislocations. How many lethargy, how many bone block, and how many DAS? Just give numbers, 1, 2, 3 if you have them.
70% letter J, 30% soft tissue.
So no bone block or no DAS. 70-30. Vivek.
Rarely bone block. Say 90 to 95% of tissue. Just
90-95 soft tissue.
rest is bony.
Which is
Rest is bony, and mostly
lethargy. So 90 plus soft tissue, lethargy. Ram.
70% arthroscopy, Bangkok, remplissage, and 20% lethargy, 10% DAS and bone graft as per the condition. So 70, 20, 10.
Okay. Jiten.
90-10.
90.
10 lethargic, 90 arthroscopic Bangkok.
90 soft tissue, 10 lethargy. Ayappan.
Sir, 70 Bangkok, lethargy 25%, and 5% is a bone block iliac rest, and only maybe 1 or 2 DAS.
His DAS has shrunk.
Always.
Thank you, Ayappan. I'm teasing you.
has got a small-
Yeah, 80%.
Pratap.
Yeah, 80% soft tissue, bungas and plus or minus remplissage. 10 or 15% of them is lethargy. ICBG only for my epileptic patients. ICBG. That is reserved for epileptic patients.
Epileptic patients.
I would go 90% soft tissue Bangkok and 10% is lethargy, bone block, others.
And any DAS?
I haven't done it, to be
DAS.
honest.
Okay. So this will help the audience understand where the world is going and where you want to go. So this is what I did. This patient is actually 8 years post-op, not 5. The slide is 3 years old. I did a very typical classical arthroscopic Bangkok repair, excellent shoulder function, no recurrence rate, no remplissage, no bone block, no lethargy. Now case scenario 2. So here is a 21-year-old male. He had a post-traumatic 3 dislocations in 2 years. He went and underwent an arthroscopic Bangkok repair, and after the procedure, it redislocated twice after 1 year. So failed arthroscopic Bangkok repair. So let us start with Jiten. Jiten, I want a quick answer. Is bony Bangkok a contraindication for arthroscopic repair? Yes or no?
No.
No. So you will do an arthroscopic bony Bangkok. Everybody agrees? Raise your hand. Everybody agrees? Anybody disputes? Vivek, your hand is not up. Arthroscopic bony Bangkok? Yes? No problem? No problem. Okay. So everybody will do an arthroscopic procedure and not shy away from it just because it is a bony Bangkok repair. Why do you think this procedure failed? This is after failure CT scan. Okay, Jiten, you want to?
I think the bony Bangkok was not incorporated in the repair. It's not lying where it should be lying after the surgery.
So, not technical error.
Technical error.
Everybody agrees it's because of technical error.
Most of the failure were technical errors.
Okay, this one is, yeah. Would you have done a different procedure on day 1? No. You would have, yes. Yes, we have a different answer.
I would have added the remplissage, that's for sure.
You would have had, and you'll see, can you see the Hill Sachs?
On the axial view, there's a small medialized Hill Sachs lesion.
Okay, once again, I'm going to remind you, if you look at the world literature, I challenge you, there is no indication for a remplissage for that kind of an Hill Sachs. So why would you then consider a remplissage when there is a consensus in the world that this is not suitable for, remplissage is not needed in this?
There are new studies that say you should have a very low threshold to do remplissage because that decreases your recurrence rates significantly.
Okay.
And actually it reduces the number of need for bony procedures. So I have a very low threshold to do remplissage, and if I see it arthroscopically, I would do it.
May I, have you published this data with a certain number of follow-up?
I haven't, but I can give you many, many papers that have. And now the newer trend of papers definitely says that addition of remplissage is a security to reduce recurrence rate, and the recurrence rate has now equalized that of
bony procedure. So
bony procedure.
can you define, can you quantify that what size of remplissage would you consider, what size of Hill Sachs would you consider remplissage or any remplissage?
So if you want to analyze prior to operating, you should first of all measure your remplissage, your Hill-Sachs lesion with a 3D CT scan, then measure your on-track, off-track, and see if it's an off-track or an on-track.
Let me stop you. It's on track. We are not talking about off track. It's on track. This one was on track. Now, can you, for the audience benefit, can you quantify that this size of Hill-Sachs is an indication?
Unfortunately, there is no number today that I can give to
Thank
the
you very
audience.
much. I made my point. So, now what next? So, this has failed. Let me start with you. What will you do now?
I would, if remplissage was not done, I would revise this patient with a soft tissue procedure, redo the Bankart, trying to liberate that bony Bankart really deeply, reduce it nicely, and add a remplissage.
So, revision Bankart plus remplissage. Anybody different from that? Okay, first, Jiten, you want, sorry, Vivek and Ram, you all agree with that. Revision Bankart plus remplissage.
I will probably go with the lateral J surgery.
Lateral J?
Yeah. Yes.
Yeah,
It's
same
a
here.
failed Bankart. It's a failed Bankart, and I want to go ahead with another procedure which can be more sort of a better result, which may give a better result. So I will go with the lateral J.
But are we talking justifying with backup of science to do a lethargy, or are you following the French principle, no bone loss lethargy?
Yes, if you look at the meta-analysis of a revision surgery, it backs up the bony procedure.
Okay, Ayappan is tending to agree. Ayappan, throw some light.
Yes, sir. Latage is a procedure of choice because revision Bankart failure rate is around 50%. Up to 50% revision Bankart failure rate. At the same time, if you do a Latage, even if your failure rate is only 3%. So my go-to surgery will always be a Latage.
So, Ayappan, can I interpret your statement? Revision Bankart, a failed soft tissue procedure is equal to a lethargy.
Revision, yeah.
Stop. Answer my question.
I think
a failed
it
soft
depends on
tissue,
the reason of failure.
a failed soft tissue procedure means you will do a lethargy. Yes?
Yes.
Okay. Two people agree. Now you want to say something?
I think it depends on the reason of failure. Whether it's technical, that bone block, that bone fracture can be incorporated or not. For me, I think it depends. I will go back and see the video of the procedure, how it's done. If it's just a soft tissue incorporation, that's not good. For me, I think that piece of the bone is big enough that I can go and revise it and use that piece of the
So revision soft tissue procedure. Jiten was trying to say something quickly.
So I think the reason I would do a Latage here is because that's the only best possible result in this situation. Second operation. So this patient has already had a failure. I may be a better surgeon than the previous surgeon, but then I cannot guarantee even second time because all the tissues, the bite have been taken, there may be more damage. So I would rather go to a more predictable operation at this stage, which is a Latage operation.
Okay, Ram.
I think I wouldn't say automatically go for Latage. So I would go for revision arthroscopy.
In this case, revision.
But revision arthroscopy, remplissage, release the bony Bankart and incorporate. But I will just inform the patient that if there is a situation where the soft tissue is not good, perioperatively I should be having
Intraoperative you may switch. Okay, got it. Okay. Audience has got it. So there was a revision arthroscopic bony Bankart done. This is now more than 5-6 years successful, no recurrence. A revision Bankart was done. Now, next question.
Sir, not everyone is Sanjay Desai.
I appreciate that. Thank you so much. Is the size of the bone, when you have a bony Bankart, is it a limiting factor that, oh, I cannot do this arthroscopic, I should do open or something else? Is size of the bony Bankart a limiting factor starting with...
No, I think with the new techniques and the new the instruments that we can use today, I think we can achieve...
so any size you will do arthroscopic bony Bankart. Vivek, anything controversial or different?
I think more than 30, 35%, 40%, it's little tricky to negotiate all instruments around.
So elaborate on that. So what is your cutoff? This I won't do arthroscopic.
It's hard, but once you say that it's a glenoid fracture, inferior glenoid
Glenoid fracture,
then you say, I'll do the open or whatever screw, otherwise the arthroscopic.
Majority, Ram.
Majority arthroscopic. If it is a thin fragment, we incorporate above and below repair, labral repair in continuity. If it is a big fragment, I do a double row technique. So possible to fix almost all fractures
Arthroscopically.
Same.
Okay, Ram, apna Ayappan.
Sir, how bigger the fragment, if it is like 25% above fragment, I would definitely put in a screw fixation. Additionally, I would do a sturdy fixation than a soft anchor fixation. But I would definitely try to do everything arthroscopic.
Stop. Screw fixation will be cannulated screw over guide wire.
Cannulated screw. Yes.
Okay.
Yes.
Have you done, how
Yes.
many have you done?
We have published. We have, one is already published. We have done 2 techniques, 2 papers.
Okay, okay. And you have, when you do, because I have done a few,
Yeah.
when you do a cannulated screw fixation, do you use any tool to stabilize or hold? Because I have a special Peter Habermeyer grasper which is cannulated. So do you?
What the technique which we do is, okay, basically we achieve a temporary reduction with the suture anchors. So we have a hold in place. Then we fix it with, so the way we do arthroscopic, we use a Mitec screw system. So where we do the Latage, we hold the jig in place, and then we pass a guide wire and then fix it.
Okay, that's useful. Thank you. Pratap.
Exactly same what Ayappan said. I will, if it's amounting to a glenoid fracture, I will try to do it arthroscopically with the cannulated screws.
Okay. My friend?
Well, if it's around 15%, which is, I think I can do it arthroscopically. If it's bigger than this, I will do it with the mini open.
Okay. Now you continue to hold the mic, my friend. So I want you to answer like this. 3B, arthroscopic, 3E, open, 3C, quickly, 1, 2, 3, 4, 5. You have 4 cases. So we have completely covered bony Bankart. So 3B, yes. 3E, C, D, E. What will you do? 3B?
Arthroscopy.
3C?
This is a bigger one, but still I will try to do it arthroscopically.
Arthroscopic. 3D?
D need to be mini open for me.
Is what, sorry?
Yeah, I need to open it.
Open. So 3D is open. And 3E?
3 is questionable. I will scope it and see, but most likely this will end up with a small incision.
Open?
Yeah.
So you are saying 3D and 3E open, probably. D and E. Okay. I want answer like this.
Yeah. Okay. All of them arthroscopic if it's fresh, and I will go with the additional image intensifier. That's it.
Okay. All arthroscopic.
All arthroscopic.
I have one.
If it's a fresh one.
All are fresh. All are fresh.
Yeah. Yes. And with the help of image intensifier.
Image intensifier. He wants intraoperative. Okay.
Sir, all arthroscopic. Everything else soft anchors, except for the 3D screw.
Except for the?
3D will go with the screw, arthroscopic with screw.
3D, Ayappan will put a screw, but everything arthroscopic. Jiten, sorry.
3D open, rest arthroscopic.
3D open, rest, and any screw? Screw?
Screws.
Okay, Ram.
All arthroscopic. 3D also can be done arthroscopic. You can put an end-face anchor and a medial anchor. I can do
that. Give him the mic, please.
I would open or mini open, another arthroscopic.
Okay.
For me, 3B, 3C will be arthroscopic, 3D and 3E will be non-surgical in my...
I love you. So this was a big wig of WHO lady, 3E, all were done arthroscopic, all did well. 3E was conserved. And this is the 4 months post-conservative CT scan. Thank you. Do not forget conservative treatment does work, gentlemen. We will now go to a very quick answer, epileptic.
The question was a bit misleading. You said how to fix it, not how to manage it.
But that was the trick question.
You would have said, if you would have said how to manage, then we would have given
Sanjay, you trapped us.
I trapped them.
Guys, if I ask you to throw yourself off the bridge, would you do it?
Roshan,
you listen to exactly
I
everything
hope I'm allowed to trap them.
You didn't give us freedom.
Okay, now quickly, gentlemen, another 2 more cases, lovely cases, then we cover the whole gamut. So let's start epileptic, maybe say surgery is indicated, he's had 2-3 dislocations. Your choice. Let's start with Ayappan. Ayappan, you look very excited, yeah.
Sir, ICBG, anterior bone block.
ICBG.
Completely agree. All epileptic patients, I will go with the ICBG only.
Anybody who has a different concept? This patient is epileptic, had 3 dislocations.
If he's controlled from epilepsy for 1 year with medication and followed by his neurologist, I would do a Latarjet.
Sanjay,
Lethargy.
sir, if
Yes.
I can ICBG with the Remplissage.
Actually, I had a similar patient.
I would do.
I had a similar patient with the epileptic where we did the letter J front and we did the ICBG for the health sex. And she's doing very well.
Okay. Okay. Vivek, you were saying something.
Arthroscopic Bankart and Remplissage.
Okay.
I have a reasonable series, not a big one. About 20% dislocations, but 80% did not.
Nice one.
ICBG and maybe add Remplissage.
Okay. And ICBG. Okay. So my question to all the expert 7 panelists is just yes or no. Do you think that an epileptic patient means you have to do a bony procedure and it's superior? Yes or no? Yes or no? Just starting from there, yes or no?
Depends on the pathology. This is a static
What is
epileptic. This is epileptic patient.
Yes.
So the epileptic patient, yes, there is high success with bony procedure
Your
compared
choice
to the
is bony
soft tissue.
procedure because he's epileptic.
Yes, for bony procedure.
Because he's epileptic. Bony.
Yes, for bony procedure, but the bony procedure also differs, Latarjet or a free graft. Because no, what I have seen is
Don't
that...
corrupt the thinking. Bony procedure.
The patient will have complication, I have seen, with the frequent later attacks of epilepsy, the screw will bend. If the fracture is not healed, go for non-union. So the complications are slightly higher with the Latarjet.
But your choice, if it is
Bony.
bony. No. Yes, Vivek, it's different. Please speak.
I'll take the decision depending upon, control of epilepsy, bone loss, replace. So I'll still, if it is about 12%, I'll still offer the arthroscopic procedure.
Soft tissue procedure.
Yes.
Agree completely with my
Okay, we have 2 wise men. Look at Jill Walsh's published paper, 2012, 94B. 43% recurrence rate following Latarjet in epileptics. The bottom line is, the key is to control the epilepsy. Once you control the epilepsy, you do as per the merits of the shoulder pathology in recurrent anterior dislocation, and you can do an arthroscopic soft tissue procedure also, as long as my friend said, you control the epilepsy for a period of 1 year. We go to the next.
It may be due to the fact that it is Latarjet, not a free bone graft. It was not there at the time. So maybe
Granted, I'm just talking about what Jill Walsh published, because they are a Latarjet country. Just I want yes or no. Do you follow this concept of IG toy and do you follow yes or no?
No.
No. Vivek, you follow this concept?
Not really.
No.
In entirety, more than 25%, yes. Generally, you have to go for a bony procedure, 20 to 25.
But so when you, which one do you not follow in this? You're not following, you're not
No,
agreeing.
I follow only the point number 3.
Number 4.
Number 3, it's more than 20 to 25%, then I would inch towards or incline towards more bony procedures. Less than 25, it's not like less than 25, I have to do this. Less than 25.
But do you agree with number 4?
Number 4,
This is,
25 off track, not really.
no.
There are 2 groups who
Ram,
say...
you agree with number 4?
number 4 is sort of additional procedure or extended indication, which is not common.
No, Bhushan, yes or
No,
no? You follow,
no.
you agree
Number
with yes?
4, no.
No.
The requirement of the patients are more critical than these numbers.
Granted,
I don't believe in this concept.
No, absolutely no.
So
I don't agree with this numbers at all, percentage wise.
Yeah, I agree with my colleagues. I think these numbers is not like carved in stone. So it depends on the patient, depends on the pathology, where it's a health sacs, how much contribution of the glenoid bone defect. This is all you apply to when we decide what to do.
So we have very wise panelists. Let me show you one case. It was as per IG Itoi's work. He had more than 25% glenoid bone loss. He had an engaging, and somebody did this as per the protocol. He did a Latarjet, he did a Remplissage, he did the works. This patient comes to me after 10 months post-surgery. Doctor, I'm in so much pain, I want you to chop my arm. Seriously. This patient came to me. So the bottom line is, as the wise panelists have said, don't just follow literature blindly. Use your experience, use your common sense. So, second last case, Roshan, we are doing okay time-wise, Roshan? Yes. 29-year-old right-handed male, 18 months since injury, came from United States, the United States, untreated, missed. Okay, so starting with my friend here, what will he do? He's 29, he's right-handed, this is the dominant shoulder, and it's 18 months ignored dislocation.
So
Your choice.
3 options: either observe, arthrodesis, or reverse shoulder arthroplasty.
And your choices?
I have to see the guy, 29, depending on his activity, maybe.
I'm the guy.
Reverse.
Reverse. He hates me. I'm teasing. Yeah, Vivek.
I would not do anything. Just observe and leave him, because what arthrodesis is not, they will usually have a reasonable movement. Reasonable. The reverse is out of question for the moment for him. If you do anything, you will actually worsen him, in my experience.
So leave alone. Ram, quickly. Mike.
Agree.
Leave alone. Leave alone. Leave alone.
Leave alone. What is his problem?
Pain and poor, some pain and poor
I
function.
will wait. Leave alone.
Leave alone. Leave alone. He was left alone. Last case.
What if he comes after a year with pain? I ask you the question now.
Huh?
What if you are really under pressure to take a decision? You are the expert, the most senior surgeon in the area. You have to really take a decision now.
Then consider.
How long can you leave him alone? He's going to get worse and worse. You have to take a decision one day.
I would do an arthrodesis.
Arthrodesis. At the time. Yes.
Okay, so here is bilateral shoulder instability, a 22-year-old female. Look at that lesion, that's posterior, and that is anterior side on the left where the arrow is. This fluffy torn labrum behind is posterior, this is anterior. Okay, bilateral female, 22. Now I'm going to show you this. I've debrided that backside, that's the lesion, posteriorly. Okay. And anteriorly. Okay, so you've got the idea? Bilateral, that is posterior, that is anterior. Now question, what is the incidence of multidirectional in your practice? I want a quick percentage, roughly.
I don't know.
No, he doesn't know. Okay, Vivek. Come on, you have all your data.
Maybe 1 in 200.
1 in?
200, 100. Very, very
1 in 100. So about?
So this is a
1%.
structural MDI. If you're talking about true MDI, which is non-structural MDI,
No,
very rare.
We have the video
this is
there.
structural MDI, you do get about probably 5 in 100.
So 5 in 100 incidents, Ram?
3 patients a year. 2 to 3 patients a year.
But you see 10,000, so we don't know
Very,
how many.
so very small.
Give us a
Percentage-wise,
percentage.
around 2%.
4-5%.
10% it is contributing to some extent. So I do extra more than my routine bank card on those cases.
No,
10%.
10%.
Less than 5%.
5%.
Less than 5%.
Less than 5%.
1 to 2%.
1 to 2%. So my data is about 2% are these kind of, out of these that you see, how many end up undergoing, they fail rehab and needed surgical intervention starting from the other end?
I would say 5%. 5%. I'm
Five.
usually very keen not to operate on them.
Correct. So if you see 10 of these, you will end up operating on less than 1.
Even though it is MDI, they will have a predominant site which dislocates. So my percentage is something like 25%.
25% you will end up operating.
Around 25 to 50% will end up in
You will
surgery.
end up operating. Jiten? Same. Ram?
MDI patients with a structural tear like this, we will operate.
So what I want
Percentage around-
audience to know is that when you see an MDI, they should have a figure in mind that,
30,
so what
30,
percentage are structural and therefore
30
operate?
to 40%.
30 to
30 to
40%.
40%.
So 25, 10, Vivek?
Yeah, similar.
Similar.
About 25, 30%.
It's a very tricky question. First, do they have connective tissue diseases or not, like Ehlers-Danlos or Marfan?
No, they are not Ehlers-Danlos or no.
Secondly, do they have a structural pathology like
That you saw on the video.
Yes, then I would operate. If this
So
patient is
what
symptomatic.
percentage of those MDIs you think do have a structural problem and therefore end up with surgery?
Yeah, if they are a real MDI, they would not have a structural, they would only have laxity of the ligaments, then I would not operate them.
Okay, fine. And how many of you, when you operate, besides repairing the structural defects, you will do an interval closure? Raise your hands. How many interval closure? Are you aware of Japanese study that 100 patients, no interval closure, 100% interval closure, no difference in the result? So why do you do it?
There is also papers saying that if you do an interval closure, it's got excellent results. Sugaya paper.
Okay.
So his Bankart remplissage interval closure.
Okay, now
For volume reduction, I am doing.
let me again,
Volume
for the younger audience,
in the space.
We are
finishing.
on finishing
last,
line.
so
Half a
here it
second.
is. I'm
Thank
on
you.
time. One last subject to think. How much percentage of the capsule volume is shrunk when you do an interval closure? It's a Japanese study.
Thank you very much, gentlemen.
That's
That
the
is a
homework
wonderful
for the audience.
show.
Thank you very much, Roshan.
Yes,
Thank
yes.
you.